So Xander and I were just having a very interesting conversation, but I think it's valuable for us to have it
Yeah.
again, right, with you guys present. So we're looking at what appears to be a dentate line lesion, primarily on the left lateral side, right? Fluid's pooling around, as you can see, it's right at 6 o'clock in my image. There's a little bit of there are small amounts of contractions that are sort of inhibiting our access to the oral side, but once the contractions let go, oral access is actually really, really good. And there's the oral edge of the polyp. So Xander and I were discussing which of the two sides, oral or anal, you would dissect first.
Mhm.
And Xander's suggestion was,
I thought, given that the lesion is quite narrow, that we start dissecting trimming on the oral side so that we can then tunnel from the dentate line. Then, if we arrive at the trimmed oral edge, open up the tunnel, put a clip on a line, put some external traction, and use that traction to actually, well, first complete your circ incision. Then, with the external traction, you have those two bridges that you then need to dissect. That was my blink strategy, if you want.
so to this, I present a counterpoint. I would normally start on the anal side. And the reason I would normally start on the anal side, particularly for a lesion like this, is, I mean, it is literally on the dentate line. So here is our, let's go around to BLI. So this is our anal edge of that lesion. So here, the problem is that we've been talking about coupled tension systems a lot this morning. So we've been discussing coupled tension systems. And this is an important point here because whatever side that we do the dissection on initially is going to retract towards the other side. So if you start your dissection on the anal side, as long as you get right to the very edges of your lateral incision, all of this by the dentate line will retract into the rectum itself. And that will give us an access to perform a classic tunnel. Now we've got decent access both with a straight instrument and in the retroflex position to open up the oral edge once we've finished our pocket. And once we've opened up that tunnel, we can take the lateral edges. Now it is reasonably narrow. However, we can take advantage of the fact that at that point, when we've sort of emptied everything underneath the lesion, we've now got decoupled tension systems, right? So if we insufflate at that point, what we'll end up with is usually we'll end up with a straight line and a round circular muscle layer underneath, right? And we can finish our lateral incisions at that point. So that's the technique I would use classically. I would make a very small flap on this side. Yeah, so I'd make my incision, go to the edges, make a very small flap on this side.
Yeah.
Just to get it to retract into the rectum, and then decide dynamically which strategy I'd use from there.
Then one question, when you are pocketing, so I assume, you're pocketing, so you're not making any incisions.
Yeah.
How do you avoid overshooting actually the margins of your lesion too much?
Doesn't matter. Well, the way that you do with any pocket is you retract the instrument out of the pocket and you check. So you regularly check.
Okay.
And once you can see that your lifting fluid is past the oral edge of the lesion, you simply invert.
And
right?
You start.
You dissect out the oral side like this, and then take care of your lateral edges. Right?
Okay.
You can decide whether to cut through the mucosal edges as you're doing so, completing your circumferential incision. You can decide to do that simultaneously with opening up the oral edge, or you can finish the oral edge completely, right? And then simply cut from the submucosal side out into the lumen side and just peel the sides away. You can choose to use traction at any point. Now, this is quite a short lesion. Normally, when lesions are longer, using traction on the anal side allows you to avoid the bunching of lesions that can occur as you're dissecting out your lateral edges, right? That's my suggestion. Okay, I'm going to mark it out.
Yeah.
I'm going to hand the scope over to you. We'll talk.
Thank you.
Can I have a knife, please?
Soft core at 5.2.
Okay.
Nima and
yes, sir.
We would very much like a nice kind of deconstructed lesion assessment about the rationale.
Let's do that. Sorry.
No problem.
Yeah, let's do that lesion assessment. Sorry, we've talked about it. Let's talk about it again. So, Xander, what's your opinion of this lesion? Do you want to tell me about how you're assessing? So let's go into the retroflex position first.
Yeah.
So we get a better overview. So that's your lesion, right?
So first we have like our blink or first impression.
Yeah.
To me, in this view, it doesn't have any of those worrisome features. There are some slightly reddisher areas, but not really that vivid, brightly red. If we look at the edges, there is not really that much of chicken skin. There is not a full deformation. Is difficult to see, but it's definitely not type C lesion, like an excavated lesion. Was not spontaneously bleeding. So blink is, in my opinion, from the get-go, it's not cancerous, or the chances are low. Then we go closer. Oh yeah, the general morphology, it's a flat Paris-2A lesion, granular in the distal rectum. To continue the previous discussion, we go closer, we look at the vascular pattern, whatever classification system you want to use. It all
Which ones do you normally use?
We use, reports, use JNet and Kudo.
Right, that sounds about reasonable. I mean, do you, obviously, Kudo assessment, do you do that with chromoendoscopy or?
Not dye-based chromoendoscopy,
Okay, right.
virtual, but it all boils down to, does it look regular or does it have some irregularities?
What do you think? Does it look regular?
To me, it does look completely irregular. There are no areas where the regularity is gone. There is some change in patterns from a bit longer vessels to some shorter vessels, but they're all structured, organized, and not angry looking.
I completely agree. So what would your sort of summarized impression be of this? What kind of polyp do you think it is? What grade of dysplasia do you spontaneously think that it has?
I think tubular, maybe tubular villus, but tubular probably with low-grade dysplasia.
Yeah, I agree. It's a TA or a TVA with low-grade dysplasia, to my eyes.
Yeah.
Yeah, I agree with that.
So why are we doing ESD then, gents?
Why are we doing an ESD?
Location.
Xander described it. I think even so, right? I think what you're asking is, what's the risk of covert cancer? And even with our impression here, the risk of covert cancer is probably, it's an LSTGH in the rectum, so probably it's somewhere between 7 and 11%. It's high enough to justify doing an ESD, but there's no overt malignancy in this.
Well, I think I'd counter by saying that the chance of cancer in this is basically, I don't remember. Do you remember the conversations in Milan of Michael Burke when he was like zero? It's zero. It's zero. It's 0%, right? And it's optically diagnosable as not present, right? The point is, I think you're absolutely agree with you about location. I think that this thing in a youngish patient, which I think we have here, is for sure something which, if you mess this up or you're not sure or you get recurrence, can be a huge problem for the patient. In that location can cause a stenosis if you have multiple therapy, blah, blah, blah. So I completely support the concept of ESD for these types of lesions, but not necessarily for cancer risk. And I think that's something we've said.
I think that's fair, David. I think that's a fair argument.
I mean, EMR for this, let's be honest, let's be very clear. We were, while in Westmead 9 years ago, doing EMR for these, and the outcomes are excellent. So, and never was there cancer in a lesion.